Thank you for your patience this morning. We just had a few technical difficulties, but we are here now. So I am here to introduce Bill Couture. He is a orthopedic physician assistant. He is also our Quebec Alternative Director. He recently retired from the Army after 28 years, so congratulations, Bill. And he is here to speak to us today on an approach to arthrosis.
Please stop. Since the room is small and I don't have to use it, sorry, I'm just going to play with the thing to make sure I don't screw it up. So I prepared this presentation. It's actually one that we give to a lot of family physicians in Quebec in French, so we translated it. I had a friend, an actual English friend, help me out. If you still find some sentences that are funny, it's normal. But yeah, hopefully it's not too confusing. I don't have any conflict of interest except my doctor that keeps bugging me about this presentation. And right now I'm doing studies also at in law and politics of healthcare in Quebec. And it's actually going to be part of the studies to do the civil responsibility of a physician assistant in Quebec as we're working along with getting the trade recognized finally back home. You'll see it. I think the presentation is going to be available. Feel free to read through all the references because there's a few, but they're very interesting, especially when we're going to get to some part of the new aspects when we talk about PRP, because there's a lot of mixed reviews. So it's important to get the facts of what's going on with that. Basically, we'll just talk about general presentation, not just of the knee. Like initially, I didn't change that slide. Initially, was asked we do it a lot about the knee joint, but this one I did more thorough. Like just let's talk about arthrosis. A lot of the new approaches, and you know, depending where you're working, what can be done at the primary care level. We're actually changing that for us too. Like we created an MSK clinic as a first line instead of being just like, oh, you're giving us a specialty consult. Well, we're actually approaching it differently, where a patient can subscribe to the clinic through the clinician without being an actual full-on consult to a specialist. This is actually translated from French. It's actually from a French doctor that pretty much just told us what arthrosis is, which basically, you know, your joint just goes to being destroyed at one point because of whatever work you're doing. You know, there is genetics into it that we'll talk later, but anything can happen when with a patient, wherever there's a previous condition, wherever they had a fracture, wherever they're just happening, that their joint space is just going to get totally messed up, and then they show up for pain. Normally, our healthy cartilage, there's no pain. Everybody's working around, and the only time that we get pain is what happens, just like if you look at what happened this week with the very awkward body check from Kirby Doc in Montreal, and next thing we know, he's got an actual teared ACL. But when you look at it, it's very normal. It's like, oh, he just got hit. There's nothing more to it. Well, his knee is he needs a new ACL. But normally, everything goes fine. And what happens at one point is just that the entire symbiosis of your knee joint, or any joint in particular, just get completely changed. Whether you're losing your synovial fluid, whether it's a joint space that's suddenly disappearing, and then next thing you know, patient shows up and he's got chronic pain. I mean, you probably see it all the time. And how does it go into the stages of that arthrosis in general? I have a picture of the knee, but it's pretty much the same picture that you would find in any other joint. You know, usually initially you'll have some mechanical issue that where your joint space is going to change a little bit. That's usually the first steps of what we're looking at. Is you look at your first X-ray, especially in the knee, you look at it and the medial compartment is suddenly collapsed. And the patient's going to always say that. It's like, yeah, I have pain on the medial side. Yeah. Oh, sorry. And I hate mics. No, it's the mic here. The people online, sorry. So usually that's the first sign we're seeing when we're looking at any joint in particular that we're going to see sign of degenerate changes is that joint space that is changing. And we see it on X-ray. A lot of the rest of the changes, we see it once we go in to do a surgery. Again, with an ACL repair, it's a prime example of an early onset of subcondylar damage. When the ACL is completely teared, your joint is no longer that stable, and that friction that's happening is just damaging that subcondylar bone. And so the tear initially hurts, but once the injury happened, it's not what continues being hurting. It's actually that contact bone to bone. And if we see a patient post a couple weeks or a couple months to surgery, you go in with the camera, and next thing you know, you're looking at all the damage that's there, and it's explaining why the patient is having all that pain. And usually it's all by that extra stress being applied to the bone surfaces. And you'll see that same kind of damage. Usually on a young, healthy patient, it's gonna get repaired. But as they get older, that damage might stay permanent. So that's why we try to operate those ACL fairly quick, because we want to limit the extra damage that's happening. Osteoarthrosis, like this is the figures that were available on Statistic Canada and Public Health. It's actually one of the most common disease right now that can be fairly well treated if we take it early. But the numbers are pretty impressive when you think of it. And obviously, as you go along with age, with normal degenerate stage that you're going to have, and it's more of the older population. Does that mean that we don't operate on all the older population and we can't treat? No, there's always possibility of, you know, operating up to a certain age. And what is the goal anyway of our patient population that we're seeing? If we're keeping them active, and even if they're past a certain age, well, you're making sure that they're going to stay healthier longer, and they don't become a burden to anybody, and they're happy of not being that burden. So a lot of times that's what we're trying to meet, even if you see that we're operating on someone that's 80 years old. You know, if we're doing a full knee replacement on them, it's because they're still active and they're going to remain active. Again, some figures that are showing in general that technically males are going to get more of the osteoarthritis. How true is that? Again, it's all taking statistics as you're looking at them. Your patient population that you're seeing might be completely different of what you're looking at on this board. Risk factors, non-modifiable, obviously there's age, male more than females. There is starting to be studies about genetics. It's pretty early on in what they're bringing up. If you look up on this, I actually have in the reference a couple of the papers that are coming up with what is maybe a genetic factor that could be predisposing to arthrosis also. And obviously modifiable, this is just a list, but guess what? It could be longer than that. But the main ones, when you look at it, is what can you change in these modifiable is one of the big steps of trying to prevent. Obviously, there is work environment that are going to be a factor in the arthrosis. Sports, obviously, there's mixed reviews right now, because you'll hear that depending on what they're doing as a sport, is it competitive versus is it just you know, a leisure activity? Okay, somebody that's doing running for fun versus somebody that's doing competitive running. Well, you'll see mixed reviews of saying that those people that are doing it to stay in shape without being competitive might be actually helping their joint when they're doing those kind of sports. But somebody that's doing it as, I want to run a marathon, well, then you're seeing the difference where that sport is actually creating damage versus I'm just doing it because I want to stay healthy. So that's why somebody that was a runner before, but now is doing it maybe just to keep in shape, as reduce his running load, might tell you that I'm actually doing better. You might hear that sometimes, and actually the literature will show you that also. But the biggies always has been, you know, for the weight ratio, but also was there any injuries prior to that? So when we're talking about knee sprains without having total LCA tear, well, do you have some laxicity in that knee joint that's creating that issue and that rubbing? Do you have a tear rotator cuff or a partial tear, or just a tendonitis that's not giving you the proper range of motion, or it's just squeezing that joint space and creating that bone-to-bone friction? And obviously, smoking is recognized as not being able to change that, you know, to promote healing process. Yes, sorry.
Just with regards to sports, I hate running. This is Is there a limitation, like, is there a definition for competitive? So you mentioned
So,
fair concept, fair
yeah,
distance, or-
not really. They mention competitive sports. And when you'll see a lot of presentation, or even when a sports medicine are talking about it, they'll say really like competitive as, but again, they're not, I didn't research in depth saying, are we talking about a, the 1,000-meter runner versus the sprint runner, the short to long distance marathon, or the ultra marathon. I didn't do an in-depth, but if you look at it, they'll mention competitive as really you're doing it, because you want to achieve something. That's the main definition of it. So yeah, it's a good reason. When we talk about the arthrosis, obviously there's always going to be the location we want to talk about, and where is it? Do you have more than one joint? I'm not covering in this rheumatoid arthritis. I'm really just covering arthrosis, because that's a totally different, like another ballgame and another disease process. And really, it's how we're going to achieve to treat the patient is, the location is going to tell us what are we going to be required to do, or what we're going to look for in these patients. And surprisingly enough, like when you look now in the literature, you'll start seeing studies about younger patients versus just old, certain age, 40 plus. You're seeing now integration of those ex-athletes, or a young patient that had a previous injury that has developed early arthrosis. So there's more and more literature about how can we help even that younger population. That's why you're seeing more of those, why are we jumping sometimes quicker to infiltration or stuff like that, is because, well, we just try to prolong instead of saying, well, he's going to get a total knee replacement at 30 when it's not necessarily required. Obviously, like most affected that we always hear, it's going to be the knee. For the ones in uniform, we know that. But it's just a variety of where you're going to see who's going to have the joint pain. It's just to look up and basically how are we going to help, and why is it creating? Somebody could have knee arthrosis, but because of his work, it's not an issue. But then his wrist and his elbow are pain in the ass because it's required for his work. So where are we going to achieve all that? So the mean age in general, when you look at studies or at the literature, they'll say where it's going to hit in certain joint, or the frequency. Sorry, French guy. I'll get through that one. They use a mean age of about 70 for the papers we were looking at. And again, when you look at it, it's all over the place. So where you're going to have the issues reported. But again, you have to put it into place that where are they, what's the work they were doing before, or activities, whatever that brought in that pain. And like I said, there is some genetic factors that are starting to be into play. It is ongoing science on that side. So when you look, there's going to be mixed reviews in the literature about poking, and I'm definitely not a genetic specialist, but they're starting to have some good, are they going to pull up markers like we're seeing? A lot of people are going to ask for that now, especially with all the research in cancer, when you can kind of prevent because, oh, I'm finding that marker. So that's why the studies are getting more and more in detail. So for diagnosis, well, it's pretty simple. In general, it's how the patient presents to you. Usually by clinical, without doing any imaging, you already have a good sign of saying, okay, I think I know what you have. But the biggest thing, it's always that progressive picture. It's never, the patient shows up one day, it's like, yesterday I was fine and today I can't walk. Usually that's going to be, in general, it should be something else. But you have that progressive picture. And I wrote down, it won't wake up the patient, but it might. You'll read in the literature, and I'm sure you had patients probably going to tell you, well, at night it wakes me up because I have that lagging pain because and it's kind of, you're recuperating from your entire workday. So it's not always true that it won't wake them up, but it's not the same pain. It's that different pain that you'll hear, like the same thing as a stress fracture. The patient is walking around, he's a sharp pain, and then when you rest, it's actually getting better, but he still has that lagging pain around. We usually do a couple of X-ray views. In our practice, we do 3 views minimum, which includes the patella view. just to see is there any biomechanical issue also with the patella that's creating the pain. And then obviously that's a picture of really the bad one you can see. But again, the main thing of that is, and what I found out with when I really switched working with the orthopedic surgeon is we never treat the pictures, because I had a picture like that once and the patient had like a 1 out of 10 pain compared to someone else who had a less of a, maybe not that x-ray, but a little bit different, and he can show up with a 9 out of 10 pain. So the picture is indicative of something, but is it the total story? And the normal questions, exam questions of what do you see when you have OA findings on the x-ray? You're pretty much seeing there, and it's true anyway, is that's what you're gonna see. But that was our typical one that I think I still remember having that question. The main imaging usually is x-ray. That's usually the only one you need, but there is other availability. Whether you're doing a CT, or is it found sometimes just because you're doing an exam on someone and you're doing imaging, and sometimes it's a secondary finding that you might have. And that happens a lot. Patients are showing up and you have it on consult because you get a secondary finding, but does that explain the final pain, and what can we do to help them? I just like that one. Sorry, it's in French, but basically the knee pain is one thing, but when we do our clinical visit is like what's going on. And the main thing is we're trying to prevent what's going on with the osteoarthrosis. And it's how can we manage the patient expectation? That brings back to that first slide. You know, how can we really help them? Well, the first question that we need to figure out is, okay, what do you have? And an example of that, and actually we were talking about it earlier, it's like you have a patient that's a construction worker and he just wants to keep working, and when he gets home or when he does weekend activities, he wants to be able to do them. That's a good indicator of, okay, well, I know what you're going to tell me, whatever treatment that we try to approach, and are we meeting that goal? So I think that's like your biggest point before jumping to saying, oh, we're going to just, you know, do a total knee replacement. So usually we want to treat the pain as part of that expectation, improve the range of motion, but the biggest one is to improve the quality of life. Like that's what they're going to tell you is, I can't do that activity anymore. I can't play with my kids, or I can't play with my grandkids. I'm having issues at work, or it basically I'm starting to be no longer as active as I was, and I need to stay active, and it's affected me. So that's that big picture of how it can affect the patient, and what when we usually try to help with. And that can be done at any level. It's not just us. That's why we even moved that, like I was telling you earlier, we're moving that clinic to even seeing the patient as a first line instead of having that specialist meeting. And obviously the non-pharmaceutical is anything we can change from the patient predisposing factor that are modifiable. We're going to try to have a discussion with them, and whatever we can help them with that is available for them. And the range of treatment is huge, and a lot of things that, you know, I was used to in my prior, like when I was in the military, obviously, is let's check the biomechanic and what's not working. But with the civilians, what I found out, with my new population, what we're looking at is, okay, what's your work? Trying to understand what are all their jobs, and it's surprising what they can tell us, or what can be, how we help them think of what can help them also. So it's a same learning process on my side right now, which is great. So our access to orthotics, do they have access to it versus do they need insurance? There is a range of what's covered publicly in Quebec, so I don't know like all the provinces, but things that we can help with. Sometimes it's just the first step, but it's part of the general management. And obviously pharmaceuticals can range from anywhere to, you know, Tylenol, or do they need NSAIDs, to, are we going to keep going to other management? Obviously, we're going to hear about glucosamine or other things. That the research on that are not huge. It's hard to find clear data, but, you know, sometimes if it helps the patient, you know, you're going to see it as a prescription. So cortisone injection, usually that's it. When we talk about infiltration, especially in articular injections, that's going to be the first one we're going to try. How patients are responding to it all depends. We like to say, to be very focused on saying, you know, your expectation is going to be between 0% to 100%. we don't know where we're gonna meet. Some people come into clinic after a month and they say, well, it lasted 2 days. Some other are gonna say, well, it lasted a month. And some others, it saved their joint and they're really happy. But in general, what we're seeing as a picture, it could be to total relief to 3 to 4 months. We have been seeing patients where we redo the injection, or it's seasonal. It depends on the amount of activities they're doing in that period of time. So some of them is every 6 months and at a specific time. Some is once a year. And generally, I didn't do an in-depth research to see if it's covered in most of the provinces. I know for us, like in Quebec, it's covered by by public health. So that's why usually that's the first one we use in the office, because it is 100% covered. When we talk about viscosupplementation, so those are the ones that usually, you know, is it going to be covered or is it going to not be covered? Basically, what we're looking for when we're using that is to replace that joint fluid with a synthetic that's going to act and do the same job. There is different version you're going to find. Some of them, you know, when we talk about Saint-Visc to Durolane or to Saint-Gal, they all have different formulation, the monovis that can be added. Some of them are added with a cortisone injection to try to help with the initial inflammation so that we can give it a little boost. But ultimately what we're looking for is that replace that joint fluid and hopefully recreate that shock absorption that's going to limit all that pain that's happening all the time. PRP is one of the new things that we hear about that is being used a lot. And again, in this one, one thing to think of is there's a lot of mixed reviews. In some of the documentation or the literature, what you'll find is that it might work in very well in some joints, especially when we talk about knee joints, some shoulder tendonitis. But then when you look at other literature, you'll find out for Achilles tendonitis or for patellar tendonitis, it's not like it's really not hitting the point. So it's still something that's still working a lot because of all that mixed review. And also you have a lot of different machines. Some people are just spinning the tubes, doing a couple of tubes, go in the tube to draw the medication. We've just tried like 3 different machines to see which ones are the most effective, whereas some of them are going to actually extract what you're looking for to a certain amount of actual platelets to plasma ratio. So there's so many things that you need to find out what's also good for your practice. And then when we look at is, okay, what's the efficacy of that machine? Like, is it proven that it's going to really give more relief in regards to the amount of fluid I'm going to inject? So it's still ongoing. There's a few, like I said, in the references, you'll find out that there's a few reviews that are very different. When you're looking at, okay, knee arthrosis, it seems to be really helping. But then when you look at other tendinopathy, it's a 50-50. And that's pretty much what you're going to see or hear, even if you look up like some other presentation, it's mixed reviews. But it's the same thing we've actually seen in our practice. And then the thing also is ultrasound guided infiltration now. Instead of doing blind infiltration like we were doing a lot in the past, whoops, sorry, I'm not going to touch it anymore. What we've been seeing is it's actually very effective when people are getting more of the ultrasound guided with a skill, like when you look at the literature with a skill provider, the amount of pain during procedure or post-procedure, there is a huge benefit to using ultrasound guided. Also, sometimes what's really fun is you're actually explaining to the patient what you're doing. You're showing them image, and if you take the time as you're doing it, you're teaching them what you're doing. That helps a lot. It comforts them in the management of what you're trying to achieve. And if, you know, in general, when we look at it, it's also low cost of where we want to go at. To achieve, you know, some relief in their symptoms. And it's working pretty good. There's a lot of good courses around now where they're going to teach you about every single formality of what you can do with the ultrasound guided. I mean, we're up to diagnosing other diseases. I'm not close to that yet, but it's interesting. And obviously, once all else fails, because we tried every conservative management, sometimes we don't have a choice, we make it to surgery. And obviously at that point, is it going to be a partial knee replacement? Is it a full knee replacement? Are we just doing it's rare that you just do patella, but it's all going to depend what's going to be the best for the patient. And usually we try to hit a certain mark. We don't try to operate the patient too early, but sometimes you don't have a choice, you have to do it. And then once you get in age, it all depends what the patient present as. What are the other comorbidities they have in general, but there's not really any limit of what you can do. It's just what benefits we're looking at. And obviously we keep talking, especially for us as PAs when we're meeting patients, make sure that it's a proper informed consent. It's what are we looking at when we're talking to the patient, when we're meeting them? Do they understand the entire procedure? And especially that it's not always curative. It might not help them to have the full knee replacement, and that's an important part. Like for us, we see 80 to 20%. So 80% is going to be we change their life, and then we have a 20% that it's like, I was expecting more. And out of those 20, we see about 5% is like, I'm not doing the other knee. So it's very important that they see that expectation that, yes, by the way, it might not help. It might not be the complete, symptoms healing. And we've seen even patients that the first knee went super well. They had complete pain relief. And then we do the other knee. Whoops, that didn't work so well. Not because of complication, we didn't achieve the same amount. Like their expectation was so high because the first one was very good, and then the next one, just because we didn't achieve that 100% or whatever 75% of the expectation, it does change. And obviously, like there's new techniques when we're doing all the arthroplasty. The ones we used a lot is computer assisted. We actually do all the measurement on the initial x-rays, but then during the surgery, we actually bring the computer assisted measurements, usually confirms what we're looking for, where we want to do the placement of all the hardware. Because there's other complications once the hardware is not properly placed, like whatever it's too anterior or too posterior. But it doesn't replace the initial measurements. You have to have those true measurement initially, so that when you're comparing to your computer assisted ones, you're like, okay, yeah, I'm hitting my mark. And we're not using robotics. I've actually talked to colleagues that are looking into robotics, and that's going to be probably the next step at one point where it's going to be more precise. So that's going to be, I didn't research it more, but it's something that's coming up. Obviously, it's going to come up at one point where we're going to be very happy to see where it is. Is that going to help a lot more of what we're looking for? And basically, when we talk about referring, the main thing we're saying is like, have you, did everything else have failed before they have to go to second line? And is there other availability clinics in the area? And that's what they've created the ortho department, the hospital I'm working at. They created that secondary clinic that they're transforming as what they call a MSK, not just a true ortho consult. It's something easy that can be readily used by local physician, so that we don't need that. Okay, you need to send me a consult. No, it's like, hey, can I have my patient being seen? And that's actually where the asset of having a PA being employed at. That's something that I've been helping a lot at, because I can do that initial consult to see where they're fitting. And by discussing with the team of surgeon, depending on where the pain is, they all have their own fellowship specialty. And then we can decide, well, let's go with the initial plan of treatment, and we'll make sure next time we see them what's going on. So we're trying to lower that threshold of availability of service for all the family medicine. And the major area where we're at also is it's just that there's less physician, because we're close to Montreal, but we're far enough that you see already that difference. So it's a good example. We're hoping that, knock on wood, it's going to work fine. It's working fine, and I think we're going to be too busy at one point. So arthrosis has always been a problem. We just have good data now that's showing how much is creating issues, but also I just think that people are more aware of, since there is availability of treatment, it's not going to remove you from your workplace. So how can we help you to stay as an active workforce. As before, you know, you would go to see your doctor and people would look at you around, so, oh, well, you can't do your work anymore because you need this and that. No, we're actually helping them carry on with their career and treating their pain. And we still do a step approach, which was the thing that, you know, initially when I first started, like even as a medic, you think everybody's going to get injections, but the surgeons don't, that's not always the true things right off the bat, and never inject a joint 3 months prior to a surgery. I haven't done it. They just keep telling me. You can inject another joint, but not the one that the surgery is going to be on. But yeah, I think I got it now because they tell me enough time. But you know, the step approach and the manage of expectation, when we're looking at it, when we're talking to that patient, that's how we're seeing how much we're helping them, and how we've been seeing that even with low level infiltration or you know, getting them around to having the proper specialist seen, and sometimes it's just an orthopod or someone that can help them with foot orthotics or any other orthotics. It's amazing how much it's been helping. We have them that some of them just seen physio to have, you know, self-taping they can do. Next thing you know, they no longer have epicondylitis. So yeah, it's I think like it's been helping having that, you know, lower level primary care kind of approach. That's not the point of my presentation, but just trying to push it on. And we need to fail every other management before we join to arthroplasty. It's not because the surgeon wants to operate all the time. First off, anyway, there's a waiting list. So even if we would want to, it's not going to happen. But there is time that patients that when we even see them, they're already on the list. You know, because through history, you know, they're having 10, 15 years pain. They've been, you know, sedentary for 10 years now. And it's just that it's their first time that they have the chance to see maybe a surgeon. And obviously they're going to be on the list and they're going to get operated maybe already as the treatment plan. So anything is possible. Again, it all depends on their patient. Wow, that went fast. Sorry, that was super fast. Any questions? So thank you. Hey, oh, not you.
Thank you for the presentation. And I have a question about, are there any studies showing like fat grafting instead of like PRP injections into joints and stuff right now?
There is some. I didn't do a lit review in this particular field for this presentation, but I've seen it as doing my lit review. They're starting to show different stuff, just like can you just do some partial resection of osteophytes as an initial surgery without doing full on? But it's really depending of every single patient what's going to be the best management for them, and that's what I've seen when I first started. Like I said, so you're going to do a partial knee change on this person? It's like, no, I'm just going to go and shave this off. Oh, okay. And then the next patient, no, actually, no, this one we're doing that. Why? But sometimes it's really patient's presentation. So yeah, it just need to be looked up. Same thing with revisions. Like one of them that you hear a lot is the patellar clunk after having a total knee replacement. And surprisingly enough, it's not always doing the actual plastic replacement. There is just secondary tissue that was in place, and we just go in arthroscopically and you remove that piece of tissue, and then whoop, problem solved. That's sometimes one of the first approach. Depending if anything was, you know, on the measurements, was there just movement of the hardware also? Obviously, the range is like, yeah.
But my big question is for primary care. These patients are waiting a long time to be seen, especially in rural areas. So what's something in primary care that we need to help them stay active and mobile while they're in that?
Anything in there, really, like I mean, I was a primary care physician assistant, and he trained me in infiltration, and we have family med doctors that are trained to do also to get all the way to that level. to do a ultrasound guided joint infiltration. So even in primary care, you can get trained to do all that. And that's why we're but I mean, the first step is what we're also doing, especially that's a big part of my role, is helping the patient, navigate through what else is available. And so physiotherapy to see, is there any biomechanics that's not helping? So I make sure to be able to direct them to that part. Is there any orthesis or orthopods or anything else that they might be helpful for them? So that's also a part of that we're trying to direct. So it's the same thing we were doing when I was really a general practitioner in the military, is we hit everything first, and then after that we see how we can help with maybe a specialist. Well, yeah, there's your range in primary care is like, I consider myself primary care. I'm not an orthopedic surgeon. I'm helping them more as what I believe being a primary care PA, but in the orthopedic setting. That's how I feel that I'm helping. Yeah. So we have documentation that has been built by the clinic, and we have 2 physiotherapists that works, especially because of the post-operative. And with them, we were kind of able to develop some training aids that we can give to the patient, because yes, you're right, physio is hardly ever covered, except if you had an injury, like a significant injury, like a fracture, or you just came off an actual surgery. So there is a lot of documentation that's available. Like, that's how we used our tools around. And even, yeah, we had physiotherapists in the military, but what's my chance of having them being seen maybe for something they can try to help themselves? They did the same thing. They gave us a quick handout of, hey, can you try that? And a lot of times anyway, physiotherapy for knee, like especially for that kind of pain, it's not something that's going to be very intensive, maybe initially, but after that, it's going to spread out over time, or when they need it. Like, that's my example. Like, sometimes I have a flare up, I need to be fixed up because my normal exercise don't work anymore. So that's a good question, and that's how I feel, because that's how I feel I can help the team. Like, coming from a primary care setting, that's how you're trying to achieve all that help and I think that's we're at the prime level to say, hey, the earlier we help them, and the better it's going to be in the long term. And lucky enough, I think we're seeing more of those early patient now, not the person. I mean, we had one that came to us at 75 having pain for 25 years, and their knee joint it's not that X-ray, but it was similar to the one I showed, and just finally being able to help her was like a miracle. But again, she never talked to her family doctor about it, because for her it's like, well, I need to work. It's not the same reality. So I think that's why, like, the modalities of treatment are changing a lot. Sorry, it's like a 10 minutes response for a one-line question.
So be a disability that's sort of a guide for when they're going to start looking at replacements. Like, if we're managing it in primary care setting, at what point do we go, okay, now you're ready for a knee replacement, we need to get you to see the orthopedic?
So the real one is, we failed everything else to help. Like I said earlier, we don't treat the X-ray, but sometimes the X-ray is also going to tell you, okay, we don't have a choice. When you get a bone-to-bone, failed all conservative management, that's pretty much, okay, it's going to happen. That's usually the big sign. The results, when it's not completely bone-to-bone, that's when sometimes they fall into that, oh, we didn't achieve that full pain relief after surgery. So that's one of them that I've learned with my surgeons, that when it's not completely bone to bone, that's usually an example of there's still modalities we can try. But when we failed all that, then okay, how old are you? How can we help you? And is it gonna be, are we gonna achieve what you're looking for? And also, is it pertinent to do it? So really, it's the person. Yeah, it would be easy to say, like I said, a bone-to-bone knee joint on this person. We had a similar case that we did one knee, but not the other. The other knee is completely pain-free, but it was exactly the same as the other one. So it's very patient dependent. I wish it was. That's the gray area that I thought I wouldn't have anymore in orthopedic.
So
I do the same coverage.
Yeah.
Age and really close because under 70, not last. So we try not to do like what we put down there is a general number, like we've said 50 to 80. Yes, it's guided by literature, but it's also what my surgeons are working at as their practice, because there's always we try to delay it just because. Yes, right now we have like we're seeing patients 20-year post knee replacement, so that's the biggest picture. Because in the past it was like, well, if I operate you today at 45, I have to revise you at 55. Now we're seeing people no revision after 20 years. So that's usually it's usually that templates. Why are we waiting? Was always that big thing is, well, we're waiting because we don't want to have to do a revision too early on that patient. So it's like, well, I'm going to wait on you at 55. But now what we've been seeing, and that's, I guess, you know, the hardware is still there's still a nice evolution in the hardware. Maybe we're going to see going into more into time. So that's like, I don't do a lot of shoulder. I do mostly ACL and knee. But that's the guideline, I think. Anyway, for us, that's what it is. And that's the nice picture now. Like I said, finally, we're saying that it's lasting longer. Yeah, now it's no longer that 10 to 12 years or 15 if you're lucky. It's very interesting, and we still can help those patients again with sometimes with visco supplementation at post-operative because they start having pain. Well, can we infiltrate? Can we give you some visco supplement? And suddenly we're still helping you, and we're not have to do a revision. Yeah, when we don't have that classic patellar clunk. Uh-oh. So usually PRP is done if cortisone hasn't worked. It's part of the modalities we're gonna try if we had a fail also in viscosupplementation. So it's another measure. PRP is not covered pretty much anywhere. It's fairly expensive. You know, I think the cheapest we can have is around $800. So that's why it's usually right now it's more of a like a third level treatment, even in things that we know that's going to work. It's just because no insurance that I know of, most of our patients have to pay it out of pocket. So that's why it's still fairly new in the research. I don't know if I answer your question. Yeah. Okay, sorry. Hey, what's up?
Thank you for the presentation. My question is regarding the combination, like the visco supplements and corticosteroids. What's like a prototypical patient that would benefit from those, or what are good indications for using them?
So, like somebody that shows up with, he's due for his shot, like let's say of hyaluronic acid, so French guy. So if I pronounce it right, yes. But he shows up and he has like a really good onset of pain and inflammation. We're just gonna give that extra boost of reducing that inflammation, and hopefully that's also gonna help the viscosupplementation work. No matter what, when they have that flare up of inflammation, it's gonna, whatever you're putting in can have an issue, right? It can play with the management of the treatment, just like if you're really sick and you're having gastro and a headache and you take a Tylenol, well, guess what? That Tylenol is not gonna do nothing because it's gonna come out either way. So in general, what we've done is a patient with a massive inflammation, lots of pain, we're gonna give him you know, obviously we ruled out everything else. We didn't have to do a tap of the knee or anything, but yeah, so we've done it. It's not often, but it happens. Any other questions? Anyway, I think it's going to be available. Go read it was very interesting doing the lit review because it's, like I said, it's a presentation we've been doing fairly often. And even for me, for the PRP, it was very new to me when I started working with ortho. So it's an interesting field, but again, it's a lot of mixed reviews, but I guess more we're going to go along, the better information we're going to get. And yeah, the training, like, don't be afraid to go and see the echo training. Like, I was kind of concerned initially, but it's actually a good training. And that can help in primary care, and it works a lot on the patient. Just doing that echo, putting that echo on them also secures them of what you're doing. You're telling them that, you know, I know where I'm going. That's also helping a lot. Thank you very much.